if we kind of start from like beginning, patient comes in,
Hmm.
they have lateral ankle pain. We have some
Hmm.
PDXs there. With as far as imaging is concerned, what are your thoughts on, you know, imaging for these tendons? And is it in fact, I've kind of heard mixed things, right? That the
Mm.
MRI imaging isn't really, that doesn't isn't going to give you necessarily the information that is needed as far as addressing your clinical, treatments.
Yeah, with imaging, I always go, what is going to cover most of your questions that you have? It's down to the clinical exam. So if you have done an ankle sprain and that sort of started things off, and we've got a a swollen ankle, we've got a potentially still consistent swelling over the ATFL, or maybe midfoot irritation. Like there's all sorts of things. I generally favor MRI because it's going to answer all of the questions. We've had an injury that we know has a likelihood of a talar dome injury, a irritation of the and itself, a lot of other joints in the area. We know the subtalar joint, located really closely to the ATFL. When we have symptoms and questions and we're not getting where we need to go, in that case, I often favor the MRI. It answers more questions. Whereas if we get a ultrasound, we're not going to get a look at all of those other points. So when we talk about especially imaging around a tendon, the question really comes down to, you know, not just what is the best for that specific tendon, but what's going to answer all those other questions as well. And so I will favor generally more ultrasound because it's going to give a dynamic image. They can start to load it. They can start to see a whole bunch of stuff. And if we are just going, it's just the tendon, it's just in the groove, it's a cheaper scan, it's a dynamic scan. I have a place that I really like to use. They're really skilled. And the fact is, an MRI, you're only going to get so many slices, and that tendon's only going to appear on three or four of those slices. How much info are you going to get? Whereas if there's so much more going on, and I'm just like, wow, I really want to cover off on all of these other pathologies. Um, if we're potentially dealing with, is it a tendon issue or potentially a stress fracture in the base of fifth? It's just really irritated insertion and it's kind of swollen. I'm probably going to favor the MRI because then even if it doesn't give the best information, it's going to give us something and it's going to rule out the other things. Because whether it's a big tendon tear or a small tendon tear, I feel confident and comfortable with using my clinical reasoning to
Yeah.
guide whether they stay out of a boot or go into a boot. Because most of that decision is going to be around the tendon tolerance of symptoms and how they're going and their trajectory more than it is imaging. But around bone, it's the imaging.
Yeah.
The imaging tells us that we need to offload it.
Yeah. So the clinical assessment, your clinical assessment guides that treatment more so than necessarily what you're seeing from a tendon perspective on the MRI. But with bone, you definitely have to rule those things out.
Yeah, and I think that's where I like the
Yeah.
why I sort of did the post on the perineals because we can find all of these other things about the tendon that could be an issue, the overstuff, accessory muscles, the retromalleolar groove shape. We can find out all of these things that might be impacting it and say, do we need to manage those or not? But when it comes to the actual tendon, if it's a chronic tear, we generally worry about it less. We lean well away from immobilization and conservative. And we say, how do we keep you as active as possible? If it's acute, we might pull them back. But again, that decision is really based on how that patient's going, as long as we've ruled out the other bits. So it's yeah, I don't that's kind of I find where that sweet spot between imaging, we shouldn't image slash we shouldn't be focusing on imaging tendons and things too much, but also still imaging enough that
Yeah.
we don't miss those points. It's the goal of the imaging is probably a fair bit different, rather than just going, I want to grade that tendon.
Um, okay, that was very helpful. Thank you. I wanted to move into strength testing. So as I was kind of going through some things, and some of the information said that it's not essential. And I want if you could explain that. Like, why would you say that strength testing is not essential. And I'm assuming because it's not highly correlative with, pain reduction and functional improvement with the patient. But from a patient perspective, do they like seeing that?
Oh
Like,
yeah.
yeah,
Yeah, the idea is that I have some valve equipment and some other objective strength testing that I like. I like a lot and I use a lot. But if you didn't have it, it's not essential because you can still make the decisions. You can still, I think, decide because let's say, for example, someone comes in and you're kind of going, okay, can they run again? With a perineal pain. Well, you've got a side hop test. You've got a forward and back hop test. You've just got a standard hop test. You've got strength that they can do I wouldn't use a 1 rep max, but I would calculate 1 rep max off their 5 rep max and compare left and right, both within and single leg heel raise. So we can kind of go, great, we have all these other ways to determine whether someone is ready. We can start getting them running and saying, what's your pain tolerance? We can, adjust their shoes and go, okay, if we adjust this, how much better is it? We can start to make all of these decisions with other means. But people like numbers. And I think the thing they like to see the
they
graph
sure
that says they're
do,
going
don't
up.
they?
Yeah, but, they go, I get to go, look where you were and look where you
Yes,
are.
yes,
Uh, but I'm also looking less at completely at strength because I'm always like in terms of that they have to reach symmetry or they have to um, reach really strict milestones when I'm dealing more with your standard person that wants to go for a run. It's also not super important because I'm also not using it to reach a really specific threshold that I know that they have to reach to do their activity, like an elite athlete or like even in quite competitive recreational athletes, where we say we want limb symmetry, we want to be able to do this many calf raises, we want you to be able to do this much on this, like we got more strict criteria. That being said, for day to day, I like the strength testing equipment because I also get to see things like time to peak force, rate of force development. And sometimes I find these numbers when they're not building strength, I can't quantify rate of force development in those other tests. I can't quantify time to peak force, but I can show them and I get to say, hey, you haven't built strength because strength can take a long time. And part of that can be limited by your tolerance. And part of that tolerance can be limited by the fact that everything's really swollen and irritated. But guess what? You are getting more confident with
yes,
your foot because your time to peak force, so how fast and how confident they are with moving, has improved.
yeah,
Their rate of force development has improved, which was then saying, hey, it was artificially, not artificially, but it was restricted by, how confident and also how comfortable with moving it and the swelling and the irritation. And that's getting less.
yeah,
And people like that. And I can't give them that evidence without it without that anywhere near as much. So I say people like numbers, people like graphs, people like seeing that they're getting better, and sometimes as well, it's a double-edged sword. Sometimes people aren't getting better,
yeah,
and I think that's also been a useful tool to sort of reinforce and say, hey, I told you it was going to take a whole lot longer. This is the number saying it is taking a whole lot longer. Or, hey, it's not getting better. Maybe we really should get that scan that you weren't really sort of super sure about. I've got some numbers here to say that we aren't changing at all. It's not, it can be disappointing for people if they're not getting improvement. And so we have to be aware that it's not just put them on and it's going to motivate them. It can be demotivating if we're not using it appropriately, which is, again, if it's a double-edged sword, it's also why it's not always essential in my sort of what I like to tell people.